Welcome to the official podcast of the Ogden Surgical Medical Society. Since 1946, the Ogden Surgical Medical Society has been educating our medical community. In this podcast, we bring you the voices of medical experts in your community and around the world. Please note that the opinions and ideas shared on this podcast are of the speakers, and not of the opinions of the Ogden Surgical Medical Society or its board. All medical topics discussed are not to be taken as strict medical advice, and individual clinical judgment is warranted when applying information to patient care. It is the responsibility of the listener to judge for themselves the applicability of the information discussed in regards to their medical practice.
Welcome back to the Ogden Surgical Medical Society podcast. We are excited to interview the Ogden Surgical Medical Society's 79th president, Kirsten Baca, MD, with her upcoming May 14th through 17th, 2024 CME conference in patient safety in primary and specialty medical care. I'm Dr. Moore. I am the president of the Ogden Surgical Medical Society for 2023. I'm also professor of medical laboratory sciences, and I teach clinical chemistry at Weber State University.
I'm Kurt Reifelman. I'm a family physician in Ogden. I've been in Ogden for about 30 years, and I've been a member of the Ogden Surgical Medical Society for all that time. I'm currently serving on the board as a CME director. I work at a community health center, Midtown Community Health Center, and I'm just excited to be with you guys this morning.
Today, joining us, we have Dr. Baca, who is a board-certified anesthesiologist and pain medicine specialist. She practices 100% pain medicine in Clinton, Utah as a solo practitioner with a physician assistant and team at Glacier Peak Pain Care. Dr. Baca started her medical career foundation with an undergraduate degree in biochemistry with a minor in chemistry from Virginia Tech. She then went on to graduate medical school from Johns Hopkins School of Medicine and then completed an internship in internal medicine at Mercy Medical Center, followed by a residency in anesthesiology, then a fellowship in pain management from MGH, Massachusetts General Hospital. Along with her medical practice, Dr. Baca is the mother of 5 children aged 4 to 16 years old. Now, I can't even believe that because I have 3 crazy kids and they are just taking it out of me. I love them with all my heart, but it takes a lot to keep up with just that. So 5, that's amazing. So Dr. Baca and her husband, Andrew, he's a patent attorney in Salt Lake. They both believe in giving back to the community, which we love here at Ogden Surgical Medical Society. And we are so lucky to have you, Kirsten, leading our CME Medical Society and the community. Thank you so much.
Thank you. It's a pleasure to be here. And I'm honored to have been selected to be president of the 2024 conference. I'm really excited to talk to you about what I have in store for us.
Dr. Baca, you have selected patient safety as your conference topic this coming year. What inspired you to select this topic?
That's a great question, Scott. Thanks for asking. Anesthesia is patient safety. As an anesthesiologist by training, it is a subject that is very near and dear to my heart. It is at the core of what we do in the operating room, and it is born out of decades of experience by my predecessors using advanced technologies to induce anesthesia, maintain unconsciousness, and safely emerge a patient. Anesthesia is a science, it is an art, but it is safe now because of where we've come from. The chances of dying from anesthesia are less than that of dying in a car accident or of getting struck by lightning. This level of safety hasn't always been present in the operating room, but it is there today because of things like safer medications, safer machines, tools, pulse oximetry, capnography, safer practices, and really importantly, a safer culture. When I started training, the checklist manifesto by Atul Gawande was released or recently published, and that made a huge splash in my practice. He is a Harvard physician, and so perhaps that was part of why we took it up so readily at Mass General Hospital. But we started doing timeouts, and I say we started doing timeouts. I was a brand new resident. I had never known anything different, but the entire culture around me was making a huge shift as the circulating nurse asked everyone in the operating room to stop, which is a huge ask, and take just a few moments to review, do we have the right patient? Are we doing the right surgery? Are we taking care of the right site? Do we have the right medications? And for me, it became secondhand. For the rest of the operating room, it took years for people to get used to it. But I witnessed several occasions where that simple timeout really made a difference. Maybe somebody's allergies to penicillin got picked up, so we decided to switch the antibiotic. But little things like that worked its way in, and having a culture of safety really left an indelible mark on who I was as a young budding anesthesiologist and where I've gone from there. Today, I practice 100% pain management in an office-based setting. So I have a very different life than when I did when I was training. And so it's taken a lot of adjustment. I still apply the techniques and the learning of my training years to what I do. I'm very careful and systematic, but it is not the same experience being on my own in a clinic as it was being in an operating room surrounded by dozens of my colleagues. So I think that it's very important that we continually remind ourselves, people who are in medical community settings and people who are maybe in small groups or even on their own, it's important to have an opportunity to continually learn and apply and develop quality, safe techniques to our daily work and where we go with that. One thing that I've worked very hard to do, enhance safe care, is how I manage opioid medications. Everyone here has been touched by the opioid epidemic. I think there's no doubt about that. You can be in medical practice, you can be a patient, you could be just a person on the street. Opioids are an important part of everyday life. For some people, it's a devastating part of everyday life. But after years of being on my own as a clinician and trying to figure out an efficient and effective way to provide meaningful and important chronic opioid care in the right situation, but also doing that in a way that I felt comfortable with, it took me a very long time to get there. So after much trial and error, I finally have a practice that I'm proud of, whereby anyone in my clinic who receives an opioid prescription also gets a screening urine drug test and potentially a toxicology. And we found a way to do it in this clinic where it doesn't add additional burden to the workflow of my MAs. It doesn't add a tremendous additional cost to my patients. And as a consequence of being able to collect this information, we can collect information on whether or not the patient is taking the medications, if they're overtaking their medications, if they're taking their medications appropriately, or maybe even not taking medications they're supposed to be taking, like antidepressants. So this information has been invaluable, and it has definitely affected my practice. And kind of, even though I don't work in the operating room these days, brings me back to my upbringing as an anesthesiologist and why the culture of safety is so important.
Awesome. I'm going to just take a brief moment and peel back the curtain for our listeners on what it means to be president of the Ogden Surgical Medical Society. The board makes decisions every year on future presidents and then extends invitations. And you received that invitation probably a year ago. And when the invitation is accepted, we also ask the future president to choose a theme for the conference that happens in May. And you obviously chose patient safety. That created a little buzz among the board. It's something that hadn't really been discussed at this conference. And at first, it piqued all of our interest in how is that going to happen? But obviously, you have a passion for patient safety. And, over this year, as I've watched your conference come together, it's really opened my eyes onto what happens in my own practice. So I appreciate that. But where did that background come? Why did you choose patient safety for your conference coming up next year?
Well, that's a great question. And thank you. I appreciate that comment. Besides my training as an anesthesiologist, which we've talked about, and it's just the foundation of every anesthesiologist training, I was able to spend some time on elective in a simulation center as a resident. It was an amazing experience. The facility is called the Center for Medical Simulation, and it's a collaboration run by many folks affiliated with the various Harvard programs. So it's not at one hospital, but multiple hospitals will feed into it. And while I was a resident at the simulation center, I had the opportunity not only to participate in multiple simulations for myself and to learn from those, but also to create, to guide, to direct simulations and to debrief after the simulations. And I learned tremendously incredibly valuable lessons. One that I find so important that stays with me to this day is the concept of closed loop communication. At our simulation center, we had several operating rooms where we would go through the process of an operation from the beginning, timeout, induction, surgery to catastrophic complication, usually at that point. But during our debriefs, we would always talk about closed loop communication, which perhaps is intuitive to many people, but not so much to me. I always took communication for granted growing up. I just assumed people knew what I was talking about, or I was supposed to know what other people were talking about. It never occurred to me that I need to make sure that my message gets received. And so the principle of closed loop communication is you say something to a person, the recipient of your comment or question, and the recipient needs to acknowledge that they received that information. This comes out a lot when we do ACLS training and the team leader is talking to a member of the team saying, hey, so-and-so, I would like some epinephrine push, please. And so-and-so would say, I will push epinephrine. That is a closed loop communication. It's very simple. It's a little redundant. It might even be pretty annoying, but it is effective and it is safe. And it actually gets the message across. I think it's so important that I actually make my children talk with me this way. Like, we need to close the loop. When my kids come up to me and say, hey, Mom, I need you to buy, 20 fruit packs for a meeting next week after school. I would say, okay, I hear what you're saying, but I cannot remember that right now. I need you to write it down and send it to me. And once you've done it, I will confirm that I received it. Usually they send these things to me in text, and then they know that I won't miss their message. But when they try to give me their message and I'm not listening, I tell them, I'm not going to hear you. So they will come back to me later on when I'm paying attention or able to focus better. So anyway, having introduced that to my family and furthermore to my clinic has made it a lot easier to get things done and to know when things are not being heeded because people don't respond back to me. I feel like that was a very important takeaway from working in the simulation center. And I've been very happy with it. And I am maybe I'm a little bit of a zealot, but here we are. And that's my background in patient safety.
Kirsten, that sounds really interesting because, I just see this like in movies, basically. I see like, someone's on a battleship and they're like, they say, first officer or something, change course to 40 degrees or whatever. And they say, roger that, changing course to 40 degrees. It's like that is the closed loop communication. Implementation of that for myself would benefit me and others as well. I think that's a great idea. We all have different areas and abilities to incorporate this into our practices and especially patient safety. So what do you expect for all of us as a general body of physicians to be able to learn from your conference?
Thanks. That's a really good question. I'm trying to organize the conference in a way that provides a compelling argument to all of our colleagues, to ourselves, that this is an issue that really does matter. And I know that sounds a little simplistic. And I know that as physicians, we take our jobs very seriously. We take safety very seriously. We take our oath to first do no harm very seriously. But I want to give context to our audience so that everyone can have a place to start from. I'm excited to present this as an argument for safety. We'll start with a story or a group of stories. We have a movie that we're going to screen called To Err is Human. Director Mike Eisenberg will be there to go screen it and then take questions and answers afterwards. The movie focuses on the plight of a family that has been at the center of several medical errors and how they survive and move on and work to make change in our system. So I think it's a very humanizing story to give us a foundation to start our journey into patient safety. Discussion on error prevention, quality measures as in MIPS, MACRA, and other federally mandated requirements, and we'll focus on how those things can help us build a culture of safety in what we do. We'll follow with a focus next on teamwork and communication, and we'll have a fascinating story to hear from Josh Morris, a Utah native who lives in Thailand and who is instrumental in bringing together myriad interest groups that were involved in the 13 young soccer players that were trapped in a flooding cave in Thailand in 2018. He helped coordinate in a way that allowed the successful rescue. And it's very interesting to hear him go through this story and then talk about the teamwork and leadership skills that were not only required, but also can be taught to aid this. Following that, we'll conclude with the importance of continuous learning, patient engagement, and how patients can advocate for themselves, and we can support that. We'll hear from representatives of risk management and malpractice organizations, the Utah State Medical Chief Examiner, and experts on electronic medical records, and especially how they might be used for error prevention. My argument for patient safety will conclude with a keynote talk from Karen Wolk-Feinstein, who is an instrumental figure working to bring a national patient safety board into existence. This board would be modeled after the NTSB, the National Transportation Safety Board, an organization that you probably have heard about or seen, which has been instrumental in the incredible safe track record that aviation has developed in the previous decades. Right now, it is incredibly safe to fly a plane, and much of that is thanks to the efforts of the National Transportation Safety Board. And I think it's no coincidence that we in anesthesia often use the analogy when it comes to our patient care and making someone unconscious and waking them up. We often compare that to taking a plane off, flying it, and landing it safely. The things we do in medicine can be extremely complicated and have incredible consequences when they're not done right, but can be done right, and they can be done very well. Anyway, I'm really excited about that. Sprinkled throughout the conference, we'll have various things like what's new in my specialty and hands-on labs, which will include opportunities to renew opioid training licenses, medical cannabis training licenses. But interestingly and importantly, we have a hands-on tracheostomy class that we will offer for those who might be interested. And this is not just any kind of tracheostomy class. This is the sort of class that you would take for an emergency when you have nothing except for maybe a pen in your hand. We are looking for true wilderness medicine, to follow up on Scott Moore's theme last year. True wilderness medicine, anything outside the clinic when resources are not available. How can we safely help our patients in an emergency?
I appreciate, and I've watched for the past year, how intentional you've been in designing this conference. I think Dr. Moore last year set a precedent that you are just building upon. And it's exciting to know that attending the entire conference from day 1 to day 4 is going to allow us to take a journey through patient safety with various learning aspects. And of course, we'll continue to get learning on new topics and all that, but we will come out of your conference as much safer providers of medical care. And that's exciting for me. When I think about medical safety, there's all kinds of topics that perhaps get the headlines over the years, whether it's medication errors or wrong site surgeries, those kind of things. But do you have a priority, or is there some aspect of patient safety that you really want to focus on?
Yeah, I think you definitely have picked up on that. In general, I think safety is a really important issue. But there are definitely certain topics in my daily practice which really hit home to me. Again, as an interventional pain medicine specialist, I spend a lot of time not only working with my patients to do procedures in a safe and effective way, but also in certain circumstances where it's appropriate, prescribe opioid medications. And I already talked a little bit about how I finally, at this point in my career, I'm very comfortable with all the steps which I go through whenever I determine it's appropriate for a patient to get an opioid, and how I monitor that patient. I tell patients on a routine basis that once I write a prescription and it is filled at a pharmacy, it is not in my control anymore. I cannot do anything with that prescription. Contrast that personally with my experience as an anesthesiologist, where in the operating room and even in the rest of the hospital, we carry our medications on us. We administer our medications to our patients, and then we dispose of the waste. We're in control 100% there. So that paradigm shift that I took from going from hospital to outpatient required me to really try and come to grasps with patients having their medications on their own, which is fine. It's reasonable. It's safe. But I need to make sure that I'm watching. And so anyway, I've spent a lot of time thinking about opioid prescriptions in the community and how my prescriptions could potentially contribute to problems in the community, such as overdose, and how I can affect that. When I started my journey into medicine, I'm only about 10 years out of medical school. So I was in college around 2000, and OxyContin was becoming a big thing on the street. And I remember as a college student shadowing in the emergency room, hearing about people in OxyContin and getting high. And I didn't really understand what that meant, but it seemed like a really big deal at the time. And then flash forward to my training in medical school and in residency. We would round in various situations on patients who maybe came in with high opioid requirements. And the common thinking was, well, here's a patient, their MME or milligram morphine equivalent, which is the 24-hour usage profile of a patient. Their MME is X. And for perspective, somebody walking in off the street, a pretty high MME, if they've never been on anything before, might be 30 milligrams a day. Somebody who's opioid tolerant might get to 50 or 90 milligrams a day. When we get above that, we really start to see increased mortality data and risk. And there are lots of people who are at higher doses because the body can become tolerant to the analgesic effect. And so they wind up being really high. In the context where, as a medical student or a resident, I was rounding on a patient who had an MME of, say, 200 or 300 or 400, we would routinely come up with these medication plans for the hospital where somebody would be on a long-acting and a short-acting medication, kind of like somebody would be on long-acting insulin and short-acting insulin. And I don't want to dig too much into it because that is not the right way to do this. And thankfully, we, as a culture in medicine, we're swinging away from that. But that was how I was taught. And I remember making these prescriptions. But then I flash forward again to my fellowship training years, which happened right after my residency. But at that point, we started saying, hey, hold on, something isn't right about this situation. We're seeing a lot of problems here. Overdose deaths were starting to skyrocket. And then by 2016, the CDC released their recommendations, their notorious recommendations. They didn't actually say cut back everyone's dose, but a lot of people, as a result, had their opioid doses cut back, and then there were some cost to that. As I'm going through these memories, I'm thinking about an example I witnessed in the hospital. So this was a circumstance where, when I was called to help manage a patient who would come in from the community, this person was on a tremendously high MME. Don't recall what it is exactly, but it's probably 500 or 600 milligram morphine equivalents a day. And that was what was written on paper. It was written on the bottles that the patient produced for the team. It was evident when the admitting team called the pharmacy to verify the patient's dosing. He was taking something like OxyContin 80 milligrams twice a day, plus other things. So what happened was, when the patient was admitted for a routine unrelated procedure, I don't know, maybe a knee surgery, it might have been a pneumonia, I can't remember, but that person was admitted. Their opioid was continued. Patient immediately overdosed. And as a consequence of the overdose, there was a code. The code was carried out. And during the course of the code, the patient had a central line placed. The central line was inadvertently placed in the carotid artery. the patient had a stroke. The patient had a devastating stroke. And it was at this point, after he got out of the ICU, that he was on the floor, that I was called in to help with his pain management. Here we are with a patient that was in the hospital for some other non-related routine issue who now has a stroke and paraplegia as a consequence of something bad that happened. And so we started doing some digging. I called the pharmacy, verified that the patient was in fact picking up prescriptions that were in the amount that everyone thought. Then I called the primary care physician, who also verified that, yes, in fact, the patient is getting these prescriptions from me. And then there was a little pause, and the PCP admits to me that he was suspicious the patient may have been diverting the medication. He said, this person is from a small town. There isn't much in the way of resources, and medications like this can be quite an income. And he said that he was never able to prove it, but he was always worried that the patient perhaps was selling half of his medication to pay his rent. So this was a tremendously tragic event that, due to the good intentions of everyone involved, nevertheless, terrible things happened. And so I think of events like that. Every time I do something that could potentially cause harm in the community, I think, this is what might happen. And the flip side of that coin is I do ruffle feathers, and I will make some people upset, but the benefit is perhaps a life saved or a limb saved. And I always think about that.
As you were talking that, as a few stories came into my head, as a pathologist, I've dealt with patient safety issues that went poorly, sometimes on autopsy. Like that was, we all hope that our errors don't end up harming someone permanently. Now, do you have any other experiences or anything that, I don't know if you're willing to share them, that we can learn from?
Not everything that I have seen gone wrong in my life has to do with opioid medications. I remember one of my early experiences as a medical student. My first rotation, my first clinical experience was actually surgery rotations. So I spent my early times in the operating room on the surgery side of things, took me into the infamous M&M setting. I don't know that many hospitals call such things M&M, or Morbidity and Mortality Conference, anymore, but they certainly exist in other forms, I'm sure. M&M conferences are a way for us to kind of deconstruct a mistake or debrief a mistake and talk about how we can move forward, what we can learn from this mistake. And what are some, in an ideal situation, it's also an opportunity to figure out the system and how flaws in design led to the problem. So in a perfect world, we're not blaming one person. We're figuring out solutions. I'm thinking about a concept. We'll probably talk about this a lot during the course of the conference, but it's called the Swiss cheese model of error. But picture Swiss cheese. We've all had a slice. So you've got this delicious piece of cheese with 2 or 3, maybe 5 big holes in it. Now get another slice of cheese, maybe from a different block. You layer them on top of each other. Maybe 1 or 2 holes overlap, but the rest don't. Get another layer of Swiss cheese, also from a different block. Now you've got 3 layers, all with 4 or 5 big holes. But if you layer them correctly, the chances of something getting from point A to point B is very small because all of those holes overlap. We're humans. We will make mistakes. We are Swiss cheese with 5 holes in us. But if 2 humans work together and are aware of these mistakes, we can layer our Swiss cheese on top of each other, and the chances of an error coming about are smaller. So this is how systems should be designed, and ideally errors prevented. It's never just one person making the mistake. There are layers of mistakes that get passed through, or layers of opportunities for correction that get passed through. Back to the M&M conference, I'm a particular case where there was a devastating injury after thyroidectomy, injury to the recurrent laryngeal nerve, and the patient had paralysis of their vocal cord. And at that time, I remember the room and how tense it was and how hard it must have been for the person at the center of that M&M to defend themselves and kind of move forward from that moment. I took the lesson home with me as a valuable lesson to, like the recurrent laryngeal nerve is a really important nerve. You don't want to mess with it. But also because I also felt like I never want to be in that situation. I don't want to be the person that makes that mistake. But after years and years have passed and I've had time to do my job and grow and develop, I've learned about the Swiss cheese model. And I look back at that moment where that surgeon was accepting responsibility for the situation. And all I can think is, well, it wasn't just the surgeon. There are other factors that got to that point. There was nerve monitoring that maybe wasn't done. And even though the buck stops at us as the physician, there are people who support us as our team. And somebody can say, hey, why isn't there a nerve monitor? Or, hey, why don't we have a special endotracheal tube in place? Or, hey, why don't I have, whatever safety procedure needs to be in place? So I think about that M&M and how scary it was and how I never want to be in that position, but also how we really need to work together as fellow humans on this journey and remember our systems need to be redundant and safe. So it really can't just be all on one person. So that's a deep memory that follows me around. I was on a Sentinel event board or meeting, which is basically like an M&M, but a Sentinel event would be something that you just never want to happen. It could result in morbidity. It could result in mortality. It could be a near miss. So there are a lot of things that could potentially count as a Sentinel event. But in this case, this was a patient who was scheduled for a total hip replacement. And prior to that surgery was scheduled to have a peripheral nerve block to help with postoperative analgesia. The postoperative block went beautiful. Everything was done by textbook. The block set up and everything was great. And about 15 minutes after the completion of the block, as the patient's legs started to go heavy and dead, he asked, well, are we going to block the hip that hurts? And it was at that moment that we all realized that everyone in the room was focused on doing a block, and they blocked the left hip, but this was a patient who was scheduled for right hip surgery. The consequence there, an innocent mistake, but the consequence was the patient could not have an additional block, and he had to deal with a pretty painful recovery. And I think back on that, and I wonder why did he not say anything? But the fact is, I asked him that later on, actually, and he said, I thought you guys knew what you were doing. It reminds me that, in the medical community, we're looked at with respect, and we are expected to always have it right, but be cautious because people rely on that. And as a result, I'm constantly telling people in my world, I'm telling my staff, and I'm telling my patients, please speak up. If there's something that doesn't feel right, speak up and tell me. If I'm starting to put a shot on the left side of your body and you need it on the right, tell me. You won't offend me. We'll fix this and we'll figure out where it went wrong and we won't do it again. But yeah, that event definitely reminded me that I have a lot of power, but I need to empower those around me to say something.
Kirsten, our time with you today has been so valuable. I have been listening to what you say, but my mind has gone back to a part where I probably file away mistakes, errors, and experiences just like you've discussed. And they've come to the forefront. As I think about your conference coming up in May, I wonder, have you thought about having a room or a board or somewhere where we can, I almost feel like I need to get those out and write them down somewhere, but it's going to be very valuable. Let's switch gears just a little bit, though, as we talk about your conference. And as the president, have you had some struggles or difficulties putting this together? What are some of the challenges you've seen?
Oh, gosh. Well, yeah. I think that actually you literally just hit the nail on the head. I think going through this has been a little bit of an emotional journey. I mean, I would argue that none of us, or at least the vast, vast majority of us, none of us went into this for the fun of it. We all want to be there to help people, to make them better, to make the world a better place. Like that is the basic standard that anyone in our field will likely meet. Nobody wants to cause harm, and yet it happens. And so I think reckoning with that it's been hard, and it's been informative, and I'm glad that I've been able to kind of go through this. And I love your idea. I think we'll have to dig into that a little bit more. So to be continued on that front. But yeah, there have been some struggles trying to get key players from all over the country and even elsewhere. I was shocked to learn that so many people are interested in this topic. I thought maybe what I was embarking upon was maybe a little bit of a niche journey, but there really is a huge movement out there, lots of different organizations, people all over the world, all over the country, who are really dedicated to the idea of patient safety, of no patient harm, and so on. So nailing down just a couple of keynotes or a couple days worth of talks was really, really hard to do. And I'm sure that anyone can say that for a conference they're putting on. I'm sure Scott could say that about lifestyle medicine, because once you dig into this stuff, you learn just how rich a field it can be. But I'm glad to have gone through it so far.
Are there any surprises or anything you want to tease us with?
Surprises. Well, they wouldn't be surprises, would they? I've got a couple of things that I can't advertise yet, but I'm very excited about and quite confident we'll be able to present. So there are some things coming that nobody will know about until the last minute when everything is green lighted, and I'll stay vague on that front. But anyway, yes, I've got a couple of things that I'm going to bring as well that I haven't advertised yet.
Well, I am so excited for your conference, Kirsten. This is going to be great. Everyone, this was Dr. Kirsten Baca, anesthesiologist, pain medicine specialist, and I will be handing off the reins to our incoming president of the Ogden Surgical Medical Society 2024 conference. Thank you so much for speaking with us today.
Thank you, Scott. It's been a real pleasure.
Thank you.
The producers of this show were Clark Madsen, MD and MS, Teresa Puskedra, MPC, and the Ogden Surgical Medical Society Board of Directors. The executive director is Teresa Puskedra. Your hosts were Scott Moore, DO, and Kurt Rifleman, MD. Editing and sound design were by Owen Service. This is all supported by the Ogden Surgical Medical Society like you. Thank you.